Thank you for being here this afternoon. I will take on the chair today as we have some board member being rotating in and out of our board. So you're going to have to bear with me for the rest of the day. We have the quorum and we don't have anybody registered to address to the committee. So we're going to go straight to the approval of the minute from last month. Can we? You can sit. Mm-hmm. Yes.
Yeah.
May I have a motion for approval for the minute?
Motion to approve.
Okay. With the typo correction. Any second? Second by Dr. Kirby. All in favor? Signify aye. Any opposed? Motion passed. The next item we have, we don't have a chair report. I'm going to skip number 4 and number 5. We're going to have the update from our Chief Compliance Officer. Colin, welcome.
Thank you. Good afternoon, everybody. So before we get going, I wanted to say from the top of the show, thank you to Zim Zimmerman, who I got to work with for 2.5 years as the chair of this committee. It was a great 2 years. Mentorship and support that he showed to me and to the governance function is greatly appreciated. I reached out to him and told him so, but I did want to publicly say that as well before we get rolling here. So thanks to Zim. We'll start out where we start out every time, which is to revisit where we left off. So this is the December 2023 risk register. I'm going to take all 3 items in the fraud, waste, abuse, misconduct section in the closed session. As a reminder, Will came up and overviewed a couple of cybersecurity instances that had occurred. One involved social engineering, another involved service disruption, and he will be back today to talk about some cyber incidents which actually combined those 2 things. So he'll be presenting here in just a minute. And then Daphne will present on workplace violence along with her team here as well today and give you an update on that. So we want to roll into the current active risk register. I'm going to talk a little bit about annual wellness visits for a minute. So this is a requirement under or availability under the Medicare program for an appointment related to preventative services. It's covered by Medicare Part B. All beneficiaries get 1 annual wellness visit per calendar year, and I couldn't turn around for the last 3 months without CMS or the OIG coming at providers for bad practices involving the annual wellness visit. It is something where if you're essentially first to the table, you get to claim the revenue for that. And so there's some poor practice going on amongst providers. Basically, 3 basic risk buckets here. So the first is making sure from a documentation standpoint that you cover all the components of the visit. There was a fine settlement recently for Penn State University because their annual wellness visit template did not hit all the components of the wellness visit, and so that resulted in a repayment. So we have looked at that. We've examined our template internally and externally, and what we have at JPS from the Acclaimed Physician Group that deals with annual wellness visits for Medicare beneficiaries. It is compliant. It's actually very well done. We were complimented on it. So that ceased to be a risk for us. The second is the annual wellness visits, according to guidance issued by CMS, can't be billed with certain types of exam codes. We have looked at that, and our EPIC prohibits that from occurring. And so from a technical standpoint, that can't occur inside the Acclaimed Physician Group. So that risk was taken care of. And the third was a piece of guidance, not so much a rule, where the government wants the beneficiary to have advance notice. So advance beneficiary notice is a document you give them to let them know that beneficiary, we're going to do your annual wellness visit right now. And so we're looking into having that triggered, but we do have it built into the system. It is something that goes to patients in conjunction with their annual wellness visit when we do one here. So we have looked at this from all sides, feel like Acclaim is very well set up for annual wellness visits, and so we shouldn't see any issues inside the network for this, but because there was so much noise going on, I put it on here and I wanted to talk about it a little bit today.
Is that because of uncoordinated care, or is that because of, call it, if the primary care physician didn't know that that patient is attributed to that particular provider?
Can you rephrase? I'm not sure I followed that one.
For the wellness visit and all that stuff?
I think it was more beneficiary complaint driven was how I was tracking to that particular risk. I think they were complaining to CMS, hey, I showed up at X provider and now all of a sudden, I'm getting hit with a copay or whatever for an annual wellness visit that I did not ask for and didn't know that I was participating in. Second one is BAA compliance. So for refresher, for those who aren't quite familiar, business associate agreement is a contract between a covered entity, in this case, the health network, and one of our business associates, a vendor, which sets out the terms and conditions for how they will handle protected health information on our behalf. The risks here are HIPAA noncompliance. There's some legal liability aspects to that, and there's also security risks if we don't have rules contractually stating how they're going to protect our data. This is an agreement that usually accompanies every contract that involves the handling of PHI in the network. The risk for us is, as we went to look at this, due to system limitations, we haven't been able to produce an accurate accounting of the BAAs in order to then do a gap analysis on do we have vendors that handle PHI for whom we don't have an executed BAA. And so inside the governance division, we're going to have to do the long way. So we'll start looking at contracts. We start by spend. We have some people under third-party oversight, and we will go through and make sure that we have a BAA on file for everybody that handles PHI, and for those that don't, we'll go about the business of executing one. These take quite a bit to get into place these days due to the cybersecurity environment. Which is unfortunate. I think it's always been that way. It's worse now. So we want to make sure that we're accounting for HIPAA compliance with every vendor that handles PHI for any one of our patients at both JPS or anywhere in the network. Questions on that one? All right. I will invite Will up to talk to you about cybersecurity here, and then we'll have Daphne follow with a presentation on workplace violence. There you are, sir.
Good afternoon, everybody. So the security team and I usually do a lessons learned after some significant events that go on within the ecosystem of technology on a regular basis, and I brought two forward, one of which is Change Health. So let me kind of walk through what transpired and talk about some of the implications of that. So the attackers were Alpha V. It's a ransom group. It's not a nation state actor, but it's a ransom group. They gained access to Change on February 12th. They used compromised credentials, i.e. somebody's password, they got a hold of it, on the application that allows Change Health to actually allow staff to remote access into their systems. Change Health paid on March 4th $22 million for 6 terabytes. It was originally reported that it was 4 terabytes, but when they did the audit, it was actually 6 terabytes. The important thing, one of the important things that occurred here is between the 12th of February and when the ransomware was actually detonated on the 21st, the attackers were moving laterally within the systems, which means they didn't land on one system and go deep into it. They went from system to system to system based on the network design. The vulnerability was ConnectWise Screen Connect, which is an application to provide a direct access. We don't use that tool. The other issue is multi-factor authentication protocols, which are typically used to guard against such attacks. That's where you have your text message or access token to your phone. Majority of you are probably familiar with getting you got to have the digit before you can log in, et cetera, et cetera. That was not enabled within their systems. The outcome of this is the real issue is it was human error. even though they didn't have the configuration set up, which we do, so that's not a vulnerability in our system, but it was literally human error. So our after action is to continue to work with HR to improve education, as well as work on education programs with phishing and other mechanisms within our own organization, IT organization, to move forward. Any question on change?
Yeah, Will, I have
Yes.
a couple question and a comment. Is it definite that this was a stolen password that was the first step into the network?
Yes, it was.
And is it also definite that it was a Screen Connect vulnerability that
Yes,
they
it
took
was.
advantage of?
Yes, it was.
That's definite. There's another chapter to this story because after United Healthcare paid the $22 million,
Yes, there is.
another company said, wait, they didn't steal your data. We stole your data. We want the $22 million.
Well, actually, the story behind that is, again, I refer to it as a gang, and it literally is a gang. They got the $22 million, and since it's a group of nerds, the nerds started fighting over who should get what proportion. And one of the nerds decided that the proportion that they gained was not adequate to the service that they provided, so they went back for a second token.
There's no honor among thieves. But did Change get the key to the ransomware for the $22 million, or did they get anything back?
I don't think any of that information has been conveyed yet.
And as Will and I were talking, they have not actually declared a HIPAA breach yet. They have 60 days, and so they have actually not declared yet because they have not crossed over that threshold yet.
But
Although they are being sued by a lot of people right now. So.
But the Civil Rights Office actually opened a case on them, right?
Yes.
Okay.
Yes. Any other questions on change?
The only,
Yes, sir.
I mean, the big damage this has caused is especially pharmacies haven't been able to get paid. Have there been any payment delays for JPS as a result of this?
Want to take that?
Kind of knew that question was coming. So JPS as a whole, between the hospital and a claim, had limited exposure to that. We've probably been paid somewhere around $130 million since that date. And of that $130 million, we've had about $1.5 million that's still hung up somewhere. So about right about 1.1% of our total payments. What is happening is those payers that have been affected, they're switching. So they're leaving, for example, Cigna is leaving and going to a company called Zealous. So there's this conversion happening. So it's going to take some time to catch up. The other thing that we've seen internally is just a paper claim issue. So we also process claims for providers in our medical services department. So we've seen a lot of paper claims as bogged down operations for us being able to process those because we normally would get those electronically. So yeah, not a tremendous impact, but it's definitely enough that we're pursuing and watching it and making sure we get all of that. So.
But to be fair, right, the AR that we received in March and April will result of 30 or 60 days prior processing claims. So we still haven't gone through the whole cycle of our current book of business that go through since Change Healthcare hit us.
Yeah, I mean, yeah, there's some trickle down in that timing. Luckily, we use a completely different clearinghouse for both claims and remittances, so we were not affected by that at all. We use a company called FinThrive, which is one of the largest clearinghouses in the country, one of the other largest. So we've been actually pretty blessed in the whole thing that we haven't been more impacted.
Full disclosure, that was my company that I started it. I'm the founder, so it's just one full disclosure. FinThrive.
One of the many companies that DT has found.
No, we pay a lot of attention to that way back.
One more technical question. Since Screen Connect was involved, was this like a supply chain issue where their MSP was hacked and they got in the door through a third-party vendor? Or?
So what transpired is once the system was hacked, they closed down all their capabilities. They basically put up a firewall and turned off themselves to the rest of the world. So their portal was down, the systems were down, everything pretty much went into hibernation mode.
Screen Connect is used primarily for third-party vendors that...
No. The Screen Connect was the internal tool that was utilized for their own staff to gain access to their
for
systems.
desktop support.
That's correct. So let me kind of close the loop. We all remember the big attacks. I'm not going to say breach, the big attacks. MGM, change. They basically all boil down to inappropriate hygiene related to passwords. So it wasn't necessarily that somebody did a forced attack on change. They gained access by getting somebody's credentials, using the software that allows access to the individual tools, and went in through the appropriate software, so to speak. They didn't come at the network and attack the network and get into the system. Does that help? Okay, all right. Any other questions on change?
I think we
No, I
all
wanna
got
change.
lucky on that one.
So the other one occurred last March, our friends at UT Southwestern, where they had about 23,000 records that were exposed to PHI. Very quiet event, but it was significant in the fact that basically what they said, they're quote unquote, they had non-compliant department level systems. And what we're reading between the lines is that basically somebody had squirreled an application away underneath somebody's desk and nobody knew what was going on. The lesson here is we've got to get a better control and make sure that we have, from an organizational perspective, an understanding of what is actually used within the organization. And as much as people don't like IT, so to speak, or IT being big brother supporting them, there's a real vulnerability when folks go out and do their own within a department. So we do analysis on a regular basis. We sweep the network and find out who's on the network, what's on the network, what tools are on the network. It takes a lot of bandwidth, but what we're trying to do is figure out how we can do that on almost a daily basis to be able to sweep and find and see if there's anything new that comes on. Obviously, once we do that, then we have to figure out where do we go with it. So we'll be bringing it to the IT steering committee and say, if we find it, the first thing we should do is probably move it to the data center for the safety of the individual, because quite frankly, usually when somebody has something hidden underneath their desk from an application, they usually aren't running a backup. So the reality of it is, if you had 3,000 patient records and the system went down, you've got no way to get to that 3,000 patient records. So we want to be focused on the business continuity first, and then obviously the security second. So the learning here is we're going to have to start thinking about our systems in totality, not just Epic or Infor or the major systems in the organization, because it is one big ecosystem. But the ultimate on both of these is the realization that the human firewall is the weakest link in everything we do. And whether that's the firewall associated with bad password hygiene or the firewall associated with not telling folks that they had tools that should have been accounted for from a systems perspective. Last summer, we came to the board and talked about security conditions that need to be addressed. And to put those needs or conditions into context, JPS utilizes multi-control measures in a defense in-depth approach to security, which means that we basically layer. We layer our security from the point of the person trying to get into the system all the way to the security to the data itself. All of this translates to efforts across the organization. I'm not going to go into all the efforts in depth, but what I will do is point out many of what we do is foundational. We're doing network segmentation, which means that we account for the traffic by types of users. So medical devices versus patients versus Epic versus whatever, so that we can control that. Identity, services, engines, and PCIs, those are all foundational and basic. Some of the things that we're focused on are preparatory. Cloud controls, because we are moving to the cloud, and the work effort we're doing around the managed services security provider. Some are extremely technical, like our effort that we've got on foot, which is the anti-traffic spoofing and intrusion detection prevention on border devices. very technical, but basically what we're trying to do is make sure somebody doesn't pass themselves off as us by hitting one of our devices. And some of them are just enhancements of our best practices as we continue to invest in identity and access management systems and efforts to apply AI. Now, if you remember me making the mention that on between the 12th of February and the 21st of February, the bad actors basically rummaged through Change Health's databases. We wouldn't have that problem. We have been we've done several things. One is standardized on one particular set of storage devices, and then we have been applying AI to those devices. We run a series of AI tools that basically look for anomalies. If anybody that comes into the data tries to do something with the data that doesn't look like a normal pattern of activity. So we're preparing for all the future. My point in all of that I've covered is there isn't one thing that we're going to be doing with security. It's a lot of stuff. It's, like I said, the various layers are trying to address the bigger picture. So your security dollars are being well spent, and they're being spent on a lot of things to try and protect the organization. Do you have any questions?
I don't think we qualify to ask questions on security. It's a lot of
work, and
stuff.
it's constant work that goes on across the hospital system to keep the information safe. And so, Will, thank you to you and your team.
I'll pass that on to the team. Thank you, ma'am.
Do you have enough staff or dollar amount allocated for training?
We have the resources we need at this point in time for what we can consume. And as we look forward, we will be asking questions, can we continue to do a lot of this work inside, or do we have to have outside assistance to do that? That's one of the reasons we're looking at a managed security services provider to be able to help for that full 24/7 coverage.
Thank you.
Thank you.
All right, I'll invite Nicole and
Yeah, if I can have-
on up and turn the show over to Daphne.
Yeah, as they come up, so these are a couple of members of my team that I just wanted to introduce the committee to, so they know them. They're not actually presenting today, but we want to make sure that you know their names and their faces. In the peach blazer, I guess, if you will, Renee Garcia, she is our manager over enterprise risk, and sitting next to her in the navy or blue, whatever color you want, is Nicole Farah. She is our workplace violence manager. And the reason I'm introducing them to you as we begin this presentation is that this is the team responsible for the coordination of the work around workplace violence, and we refer to it more broadly as workplace safety for the enterprise. This is truly an example of when compliance risk intersects with enterprise risks from our perspective, which is why you saw this bumping up on Collins Risk Register. But as we were talking about it, we recognize that we will have a better opportunity to get more deep dive with this and report out some of those incidents through our quality committee, just like we do our Sentinel events. So that is where the bulk of the reporting will happen around workplace violence. But we did want to provide you with an overview today and talk about some of the work that we've been doing. JPS has actually been on this journey for a while now in terms of collecting data. It started off more with the areas that you would kind of think intuitively might be experiencing higher levels of actual physical assaults or verbal aggressions, and that was, of course, in the behavioral health department. So they recognized some time ago that they needed to get more information about those events and why they were happening, and then that was a partnership with them, between them and the quality department. Currently, what we've done, because we were taking kind of the same reporting tool that they had been using previously to collect information. You know, we've really started focusing on the last 12 months to really deep dive into those numbers and figure out where our opportunities are. We collect data about the event, the employees and or patients who are involved, and the type of event that is happening. Nicole, as the manager in this space, actually sees every single one of those events and will help guide where they should go to following, you know, the initial reporting. We're doing a lot of work around really encouraging people to report, because we want to know about all of it so that we can continue to deep dive on this information. We're not quite ready to report out those numbers because, similar to other organizations that are gathering this data, we want to always be able to make sure that we can say what it means before we just bring raw numbers to the committee. Thank you, Colin. So some of our observations, so currently we have these broader categories that you'll see to the left that really include a lot of there's a lot of overlap, I think I would say, between what's actually occurring. So if you have a physical assault, as you read the incident, you might see that that was preceded by a lot of verbal abuse, or there could have been some other aggressive behavior that led to the assault. And so really the goal is to be able to tease those out so that we can start to see where would the intervening action that might have prevented an actual assault, where could we have intervened earlier, so that is informative to us. So as we continue to evolve that, we want to expand the categories of events that we're actually tracking so that we can see discreetly which where the incident might have fell. And we still, believe that we will have multiple categories of types of event that a particular incident can hit across, but it will help us better be able to see where we can intervene or where we can educate to address those things.
Are we talking about patients to staff?
We're talking about all of it. So employee to employee, employee to patient, patient to staff, we capture all of those buckets. And even if it's patient to patient, which has happened before, we would expect that someone's entering an event so that we can see that and what's causing it, what area it's in. We're looking at all of that.
Tough for me to grab that that's taking place.
Yeah. And sometimes, and to your point, the reason, that we want to be able to really blow out these categories and do this deep dive is because we want to be able to say maybe there's, things that are going to be intuitive to us, that patients that are experiencing some behavioral health challenge or psychotic event may, have an inclination to drive these numbers up in a particular area. So maybe and I think what we are seeing is that a lot of these events are occurring in our behavioral health unit in the emergency department. So that's kind of what you'll see here on the next slide. But we also want to understand why it's happening. Or is it because, there's something going on with these patients, or is it because, there's a particular environment? I think, we've already identified that in some instances there was something that maybe needed to change in the environment to decrease the propensity for some of these incidents to occur.
Because you would think that there could be times then that when a patient comes in, that family does not make you aware that there's a behavioral issue.
And I'm glad you asked about that, so I don't want to, steal Nicole's thunder and Renee's, because they are working on things that we've talked about. Hey, similar to a fall assessment tool, if there were a tool where we're kind of identifying when those patients might have a challenge that might cause them to behave in a certain way, we want to know about it up front. So those are all things that we are looking at every opportunity. And then there's things that are just for the overall safety of anyone that enters our building, whether an employee, patient, visitor. So, security cameras, things that we do to make sure that we have the right lens on the campus for the safety of everyone as well. Are there any more questions around that? Were you going to add something, Reverend?
No, I'm good. I'm just getting over my shock.
Oh, hopefully that's good shock. So this last slide just kind of shows where what we're seeing now, as mentioned and as expected, where we see a lot of the events occurring are in those locations where you would expect, some in our medical surgical units as well. What types of events are we seeing? Just as an overarching matter, we're seeing, the aggressive behavior, physical assault, verbal abuse. But again, as we start to refine those categories, the magnitude of each of those particular incidents can kind of shift a little bit, because as we see, aggressive behavior could have included 4 different subtypes of events, so maybe we actually had more falling into that verbal abuse category, which to me, and I always tell Renee and Nicole that I'm not trying to lead us into where we think we're going to be. But, to me, if we discover that there's escalation happening, which leads us to another thing that we're working on, then we can say with confidence that, as we do more de-escalation training in these areas, that we can prevent the actual physical assault. So, we'll continue to go down this journey and be reporting periodically here and reporting our data out through the Quality Committee.
Thanks, Daphne.
Have any questions for any of us? Thank you, Renee and Co.
Thank you.
I think at one point in this committee, when I added this to the risk register as its own breakout category, I promised the members of the committee on the board here that I would be the organization's harshest critic when it came to workplace violence, because it is so fundamentally important to what we do. I sit with these folks every day. We share an office. These are really great leaders. All right, they're the right leaders. We are headed in the exact right direction, doing the exact things we should be doing. And so I look forward to hearing in the Quality Committee about the work that bears fruit from them. So, and I think that's all we had for the open session.
Oh, the rest goes into,
The rest is closed.
okay.
You need the what's your code of conduct?
Oh, wait, I'm sorry. Yeah, you have some
Yeah.
policies.
Obviously.
Sorry, not used to having policies. So the first one up is the LD 1200, which is the Code of Conduct and Business Ethics. This is a fundamental governance policy. It had not been revised in quite a long time. There's actually not a red line in your packet today because it was a full-on out with the old, in with the new. We wanted a document that better represented mission, vision, values, and tied to strategic planning. And I think this accomplishes that. I think it's clear and comprehensive. It's not exhaustive, and it's not intended to be. It's an easy read. As I said, it aligns with our values. There's practical guidance peppered throughout of it. I think it speaks a lot about accountability. This is the first time we're addressing leadership expectations inside of the Code of Conduct. And as Amanda and I were talking about, the thing looks amazing. Okay, so shout out to our communications team. Mm-hmm. It matters how you present this sort of document, and I think they knocked it out of the park with this thing. It is a beautiful document. I think it sets us up for success. So I thank Ashley and the HR team for partnering with us on this. This was a wish list item for me from day one, and so we're here today. I'm super thrilled about it, asking for approval for that one.
I have a question for you, Colin. In some pages here, you have, let me go by memory, I couldn't find it, like compliance@jpshealth.net.org. And then the rest of them are intranet. is there a reason why one is regular and one is intranet? And will they have access to it when they're at home, when they're trying to file a report or something on hotline?
So that probably references the hotline link, which is, actually goes through an external company. And then the intranet is where they would go to get policies, which are available to all staff members.
So that explains the intranet type thing. Okay, that was what I was worried about. Second thing is the hotline. I actually did call this morning, and the first three went straight to something like unavailable or whatever that is. Didn't ring.
On the number?
And then twice it went in, ring about 10, 15 times, and then it went to fast busy signal.
Oh.
So you might want to take a look at the 817-373-0125.
We will take a look at it. We also test it periodically, and I will say we've never had that issue with it before, but we'll run it down immediately. Thank you.
I wish I remember the page number, but I don't. But you might want to take a look at that one.
Third.
Oh, here it is.
Page 35. One of my directors so I figured this is what you were doing, is to make sure that I was reading the material as the new one. Exactly.
Say, and also in just, quickly reading through the ease of accessibility of the document, because it's hard sometimes for employees to read a whole booklet of code of conduct. With the question and answers, I give y'all kudos for doing that. That really, really is helpful.
And then the other was, there's a link on 6.6 workplace violence. That link didn't work for me. I tried on several computers to make sure.
So we're just finishing this year's cycle, but it'll go up for next year's cycle. That's where they actually do the attestation that they've received it, and they're able to download it as part of that CBL. And then there is going to be a roadshow that we put together for the code of conduct to reintroduce it to the workforce as well. So that'll be an in-person education as my team goes out and around.
And then there was one other link, the spiritual care and ethics. When you go on to that, some of the data on that is incorrect. So the director of the spiritual care and ethics is somebody different than that was listed.
So the inside the actual link. Okay. Got it.
Should we go to, do we need to go through the policy?
All right. The second one I have for you is online housing. So I think this is the third time, perhaps this is becoming before the committee. It was approved, and then there was one package of updates. This is the second update. I do look at it annually. I had it scheduled to come to the board late last year, and then the day before that meeting, the Office of the Inspector General, for the first time in 20 years, revised their compliance guidance. So I had it pulled. I went through that guidance. Our existing corporate compliance program aligned pretty favorably with the new guidance. But there were a number of instances where I thought we could be clearer on how we were describing things. So I'm bringing that forward. I left notes in the margin for you about why I was making changes. Some of it's reordered. They changed some phraseology of some certain things. But other than that, this is kind of the Bible for compliance and how we go about doing our business here at the Health Network. So I will take any questions you have on that.
I do have a question, more of not what it's saying, but what is we actually doing.
Yeah.
I certainly understand and appreciate the independence of the Office of the Compliance Office, but also very sensitive to how leadership work together in cohesive. And I guess my question is around where do you draw the line between, let's just say the CEO did something wrong, then it's a direct path to the board, or the chief chief legal officer or chief financial officer, then it's a direct path, but still needs to involve the CEO or the chief legal officer in terms of planning. I mean, if there's a breach of communication or trust, that's totally different. But if there is none, everything working in cohesive, where do you perceive the line is being drawn? Because we want to understand a little bit to make sure that everybody working together and the communication is tight at that level.
Yeah. So at the most senior level, and this is addressed a little bit in the compliance program, which I was reading through today. So if it's something involving a high-level executive and it requires an investigation, we would probably take that external to counsel. So unless that involves the chief legal officer, I would partner with her to select counsel, and it would be an investigation that is, unless it involves Dr. Duncan, included her in that decision-making process. And so there's communication, I think, on that sort of level. And then depending on what the result is, that will be then brought to the board in closed session.
Yeah, because I just want to make sure there's a line clearly defined, because day to day, you're in a really interesting position. It's that day to day, you still have a direct line to the CEO.
Yep.
And then only at the board meeting, that's when you have a dotted line back to the board for a tough question if there is something arise. But I just want to make sure that we still have that line.
Yep. My line is a solid line reporting to the board.
Concern, question?
Yeah, I had a question.
Yes, sir.
Mr. Chair. Colin, there's a definition called workforce members throughout this document. It's defined somewhere near the front. And I can't find the definition at the moment, but that includes volunteers. Is that intentional? And if so, do volunteers need to be subject to all of this document? I consider myself a volunteer. So, or could we be a little more, laser in applying rules to volunteers, board members versus employees?
So your particular role will be defined as board member, but for volunteers specifically, yes, they need to follow all of the rules of the healthcare that we have laid out in all policies. That's part of the deal of being able to volunteer. So they're subject to HIPAA policies, drug testing policies, everything. I mean, it's as if, because there are instances, I believe, where we would have volunteer physicians if certain conditions arise. And so they need to follow all of our billing rules because we would bill facility charges for that. So it's important that volunteers are included in the code of conduct and it does apply to them.
Okay, so a follow-up, you think volunteers should be included in the totality of this document? And then if you don't think that board members are volunteers, then we should make it clear that volunteers does not include board members, that we're a different category.
Well, I think board members are called out in the definition of workforce members. If I'm not mistaken, I can look.
It is mentioned occasionally, but again, I consider myself to be a volunteer.
The document itself would label you as a workforce member as part of the board.
I don't think we can be categorized as volunteer. We are appointed by the commissioner court, though.
I'd just like it to be clear so there's no misunderstanding, because I have a misunderstanding, obviously, so others might have a misunderstanding.
Okay, I'm kind of with DT. I thought if I was a volunteer, I would go and volunteer through the volunteer department to do certain deals, but serving on the board was an appointment. So I didn't think that was, it's an unpaid deal, but I'm still a board member, and that puts
Unless
me in a
we
different.
volunteer to work in certain area
Which you
that needs
can't
help.
do unless you've gone through
Right. Yeah, we still have to go and subject to background check where appropriate and all that stuff.
I just think it's good in all documents to be as clear as possible. You know, volunteers is not defined.
Okay. Well, we can add one.
I think the overarching compliance plan applies to everyone as a whole. So if there's, we'll work on the definition, but if there's not any particular parts of the plan that you think are impacted by that change, then I don't know that it would prevent you all from moving forward with an approval on the document today.
Let's do that, and if there's a way to clear that up or something like that, we can, I'll see that you guys clear it up.
Okay.
Because I think for me, the more specific, the more it gets you in trouble down the road. But that's just me. I have motion for approval.
Before that,
Yes.
there's one other question I had. And the compliance program in terms of emergency preparedness and where that stands.
Can you elaborate a little bit more?
Sure. So in terms of emergency preparedness, so let's say, and this has happened historically, so in Louisiana at the Superdome there, they had flooding everywhere else. Patients were brought to the Superdome. The care that was given there was not standard care. There were lawsuits put out because it was not standard care, and those were thrown out because it was a time of emergency preparedness. So that substandard care was allowable because there were no resources available.
So while it's not specifically addressed in here, obviously, what it would be is there is a requirement in the compliance plan that we follow policy. And there is a policies built around disasters here and disaster recovery. And so it would be
We're an
follow our
emergency
policy.
preparedness plan, yeah, so it's just outside of this.
And if that,
So long as those two are
Yeah.
linked.
Yeah,
Perfect.
synced up.
Thank you.
Approval?
Motion?
A second. Dr. Casey? All in favor, signify aye.
Aye.
All opposed? Motion pass. Third item, please.
And just as a reminder, you have not gotten approval yet on your
On the first
code
one.
of, correct.
For the LD 1200 Code of Conduct.
Want to do that now?
Motion for approval? Did you go to, we did go to that one.
Yes.
Yes.
Yeah, this is back on code of conduct and business ethics. You all did discuss that, and now we're looking for,
I assume you moved for.
Yes, motion with the
Second, Dr.
changes.
Casey. All in favor, signify aye.
Aye.
Any opposed? Motion pass. Third item, PVR 200.
This policy was just
do you want to come to the table?
added and reworded, really just to be consistent with our policy format. We wanted to make it more concise and really focus on the message that employees are not to use their employee access through Epic or any other means to access their own medical record, and they're to go through the same method that any patient would. So really, we just made it shorter, made that message more clear, and cut out the definitions. That's typically not a part of policies. It's more a part of procedures.
That's something that someone trip over, or we just find that it important?
sorry?
Is that something that was tripped over by internal people doing it, or is it something that we just miss and we
Just a
decide to?
triannual review?
Yeah, I think it's the, I
of
think
it.
it's a review that we do every 3 years. So, yep.
Any question? No question, no discussion? May I have a motion for approval? Dr. Casey? Dr. Gandhi? All in favor, signify aye.
Aye.
All opposed, no. Same sign. Motion passed. That conclude, I believe, our open hearing. And let's take a 5 minutes and then we'll go into executive closed session. It's Before, since we don't have any other business, the meeting is adjourned. But I want to take this opportunity to thank our former chair, Mr. Zimmerman, for his leadership for the past 2 years and his contribution to this institution. And he will be missed at this post and along with his mentoring and friendship on our board. So thank you.